So it's now a privilege for me to introduce Dr. LaVeist. Dr. Thomas LaVeist is actually a Brooklyn native. Brownsville, original. Right, from Brownsville to Dean of the School of Public Health and Tropical Medicine in Tulane, New Orleans. So that is the person that we have coming to give our keynote speech. He's very committed to health disparities. He's a full professor in the area. He's published a lot, original research, not just giving talks, but original research in health disparities. He's been funded by all the various organizations that we know give money to people of high caliber. He has received everything of those. He's actually received very important award that I want to mention. One of them is called the Innovation Award from the National Institutes of Health. In other words, for somebody to be elected to the extent that they will receive an Innovation Award, it means that you are really very innovative. In other words, you are very unique and special. So that was very nice. And the other one was a Knowledge Award from the U.S. Department of Health and Human Services. This is also an award that is given to unique people who are able to contribute unique material, original material to the literature in their specific expertise. And so we are really happy to have him come to give this keynote address. I mean, it's a far, far away. New Orleans is not a small distance. So we're really thankful that you continue to support the Brooklyn Health Disparities Center. But for the first time, we're in collaboration with Health First to create a series of conferences that would focus on addressing health disparities. And I think the collaboration between academics and insurance actually makes sense, because then we can have real solutions. So we are really happy that you are here to give us your ideas, and thank you for coming.
Okay, thank you. So thank you and good morning. That introduction alone was worth the trip. But it's always a pleasure to be back home. And so thank you for inviting me. And sorry that we're late. Apparently there's a marathon this morning that cuts off Eastern Parkway. So imagine, how do you get here if you're in Manhattan, if you have to cross the Eastern Parkway? So that was the challenge for this morning. So the conference title, inspired me to think. So the title of the conference is How Far Have We Come? So in thinking about the title of this conference, which is How Far Have We Come, what that did was generate in my mind two questions in response to that question. And the two questions are, well, why do disparities exist in the first place? Why do we even have this problem, which is something we actually don't talk about that often. And the other one is, how far have we gone in terms of bringing awareness to this issue? Another issue that we really haven't addressed that often. And it's like this issue of not really talking about why the disparities exist. It's a critical question, because if you're going to solve a problem, first thing you have to do is, first of all, have awareness, right? So the patient presents with a complaint, right? So there's awareness. And then the next thing we do is we try to diagnose what is the core of the problem. When it comes to disparities, racial disparities, we really haven't operated in that way, I would argue. So there was a series of surveys done by Benez and colleagues. They did a survey in 1999. They did another one in 2010. It's another 10 years now, so hopefully they'll do another one very soon. And this is just looking at how many people in the general public are even aware that there is a problem of racial disparities in health. And I've always found this interesting. So among people who are in the health sciences, it's probably 100% or close to 100%. We all know. We have these conferences, and we talk amongst ourselves about this problem. And we've known, I'd say, at least since 1985, when the Department of Health and Human Services published the report, the Secretary's report on Black and minority health. But we haven't really reached the general public with an understanding of this issue, that there is a problem with disparities. And the second issue is, why does it exist? So I ask you this question: can you imagine this society without racial disparities in health. Can you even imagine that, right? So the core of that question is, why do they exist and what can we do about it? It's almost like if we walked into the waiting room at the clinic and just started handing out antibiotics, right? Now, some people probably would get help by that because there are probably some people in the waiting room that just need antibiotics. So we would randomly hit upon the right solution for some people, but of course we would do a much better job if we first stopped and diagnosed the problem and then determined what's the right course of action. So I'm gonna say a little bit about what, some things that I'm working on, and then I'm gonna talk about this issue of the diagnosis of the disparities problem. And so first, let me just start with a little clip. This is from a film series that I'm working on called The Skin You're In, and this film series is around disparities. The goal of this series was to create a film series that would explain to the general public why disparities exist, what we know about this problem, and to try to take all of that research that we've done over the last 30 years or so and locked away in the medical library, to get it out of the library and put it into a format where people can see it. This is the trailer.
How many black people die each year who wouldn't die if there were no racial disparities in health?
Your typical American child has never seen someone be shot or stabbed.
They say 47-year-old Dupree Dunbar and 25-year-old Dupree Moore were both shot on the 14th floor of a building at the Langston Hughes houses in Brownsville.
Your stress level could be over 1,000 because every time your son walk out of your home, you're worried.
Brownsville have about 6 projects. How many you got? What we got? Van Dyke, Seflo, Tilden, Glenmore, Langston Hughes, Howard, and Marcus Garvey. So 7.
Everybody in Brownsville wants to do something positive, but it's just the neighborhood that's keeping them in.
The helplessness and the hopelessness and the resignation from not valuing ourselves that turns into self-destructive health behaviors. Eating too much, eating the wrong food, smoking too much, drinking too much, unsafe sex, all of that.
The liquor store should not be open 9, 10 o'clock in the morning. And they are, because they get business 9, 10 o'clock in the morning, because I'm not the only person that wakes up depressed.
It's stressful being black.
So that's the trailer from the series. We've completed one episode, and that one episode is called Something About Brownsville, which is an episode about Brownsville and why Brownsville has the lowest life expectancy of any community in New York. The idea was to make one film, we thought, but once we started shooting for it, we realized that the problem was just way too big for that, and that you needed multiple films to be able to show it. So hopefully we have that one episode finished, and hopefully maybe I can be invited back. I would love to come back and show it here down at Downstate. So we know we have a problem of racial disparities in health, and the question is why. And when I talk to people about this issue, it's usually 3 explanations come up in people's minds. And I'm sure when I asked you to imagine this society without disparities, some of these explanations probably came into your minds. First is that it's a healthcare access issue. If we can just equalize access to care, disparities will go away. I had a conversation with a former member of Congress who will remain nameless. Former member of Congress, I won't say this person's name, but this is an individual who introduced a single-payer health care bill in the House of Representatives every year for 30 years, represented a district in southeastern Michigan where I used to live, but I won't say this person's name if you don't know who it is. Good guy, I guess, and he was talking about his bill, his single-payer bill, and this was probably 15, 20 years ago. And I said to him, well, what would that bill do for racial disparities in health? And his answer was, well, it would eliminate the disparities because everyone would have access and they wouldn't have a problem anymore, right? So if we just can get access to care for everyone, there would be a solution to the problem. That is a myth, widely held myth, and I'm going to say a little bit in a minute about why I say that that's a myth. The other one is that, well, racial disparities will always be here because this is something biological. There's some genetic differences or biological differences between race groups that produce this. So, of course, there's no pill or potion that's going to fix that. Well, that kind of thinking crops into our brains in very subtle ways, right? So I think everyone here knows, I would hope, that there is no gene that's causing heart disease and cancer and stroke and schizophrenia and homicide and you name it, right? So that's not the way it happens. But there is a way that that kind of thinking gets into our heads. And so I'll talk about that in a moment. And then the last one is that, well, it's not really race, it's really poverty. If we just deal with the poverty problem, then it goes away, right? And wouldn't that be comforting if that were true, right? But even if it was true, well, why would it be any more acceptable that poor people have worse health outcomes than non-poor people? So that would just be redefining the same problem, but not doing anything to resolve the problem. So each of these explanations that are common explanations are all myths, and I'm going to say a bit about each of those myths, and then move on to what I believe really is the issue here. So first, the equal access thing. So this chart is from a study that was done by some guy named LaVeist some years ago. When we did this study in Baltimore, and I think it's just out of fairness to my former employer, where I have retired from, which is Johns Hopkins, that this study is not at Johns Hopkins, from Johns Hopkins. Although if it was from Johns Hopkins, I do believe the results would be exactly the same as this one. This is 3 hospitals in Baltimore, and what we did was go into those hospitals and look at every chart. It was about 10,000 charts of 10,000 patients that had a diagnosis that would suggest that they could be a candidate for coronary angiography, which is an invasive procedure to diagnose heart disease, right? So we reviewed every one of those charts, and we, using American College of Cardiology guidelines, determined who should have got a referral and who was appropriate for that referral. And everyone on this chart, according to American College of Cardiology, should have been referred for coronary angiography, 100%. The other thing I should point out to you is that we took out patients that did not have health insurance or had insurance that would not have covered the procedure. So 100% of the patients represented on this chart did have access to care, did have insurance, did show up at the hospital, did get seen by someone, actually got a diagnosis and got a chart produced that we went in and reviewed. Both of these bars should be at 100% because everyone on this chart was an appropriate, medically appropriate candidate for the procedure. But we see 2 things here. First of all, the white bar is not at 100% either, right? So we've got a quality problem because almost 20% of the white patients that should have been referred didn't get referred, right? So there's a general quality problem, but the black bar is lower than 60%. So we've got a disparity in quality problem. Both are problems that need to be addressed. Here's another study. This one is from the VA hospital in Pittsburgh, and I really like this study because it's 1 hospital as opposed to our study, which was 3 hospitals. They're being seen by the same set of physicians. They're all VA patients, so the financing is the same across all of these patients, as well as the physicians, right? So they're all on salary, and they don't have necessarily a financial incentive to either do the revascularization or not, right? Again, 100% of these patients should have been referred for revascularization, but only about 50% of the white patients were referred, which again is a quality problem, but even half that number, a little more than 25% of the African American patients were referred. So we've got a disparity problem. So here's an example of 2 studies that looked at patients, all of whom had access to care, were insured, actually did use that insurance to gain access to a hospital, actually did get seen and got a chart, and still didn't have, we still didn't have the same quality outcomes. So simply solving the access problem, while it is necessary, it is not sufficient to resolve the racial disparity problem. The socioeconomic status one. So this one is probably the easiest one to dispel. It's funny, I was on a radio show a few months ago, and I kept trying to, every time they would ask a question, I kept trying to segue into explaining that even among highly advantaged, high income, highly educated African Americans, you still have disparities. Their health status is not equal to whites with similar income and education. And every time I would say that, the conversation would segue back to, oh, well, those poor people that come to my clinic and whatever, fill in the blank. They do this, they smoke while they're pregnant, whatever the issue is. But no one wanted to engage the race issue and preferred to deal with the poverty issue, which I find fascinating. But if we simply look at health statistics at different levels of income or education, it really doesn't matter that much what the statistic is. You see a clear pattern of disparities at all levels of education and all levels of income. So clearly, higher levels of education and higher levels of income leads to better health outcomes for everybody, but it is equally clear that the benefits of education and income are such that they do not cause the race issue to go away, because there is a unique issue of race and also a unique issue of socioeconomic status. Again, both are problems, but both are independent problems, independent of each other. I just want to make one quick comment about this chart, because this is really unique. This is the one health outcome that I'm aware of where you find this. For everything else, as income or education goes up, your risk of the health risk goes down, gets less. For hypertension, you actually get the opposite for African Americans. So the higher your income, the greater the likelihood is that you will be hypertensive. So I'll leave that one open. I'll just leave that hanging for right now. And maybe when I finish my remarks, we might want to have a little dialogue about why that exists. Maybe that'll keep you all interested to come back and talk about that. So then there's this one, the genes, right? So there's this gene that's causing heart disease and cancer and stroke and hypertension and homicide and suicide, and it's causing all these disparities, right? Obviously that's crazy, and that's not the way it happens. So what's going on here? The genetic argument does slip into our thinking in very subtle ways, and the story of Bidil is a good example. So how many here, let me ask you this one, how many of you are not familiar with this drug? Don't know about it? Okay, so about half. Okay, so I'm gonna have to, for those of you that are familiar with the Bidil story, please bear with me. I'm gonna have to tell the story. I'm gonna do a very, very condensed version of it, so I'm gonna leave out some details, so don't get mad at me. But if I leave out something important, please feel free to fill it in. Okay, so Bidil is a drug that came onto the market around 10 years, well, 2005, about 10, a little more than 10 years ago, 15 years almost. This is a drug that really developed back in the 1970s. So in the 70s, new classes of drugs were coming onto the market. Drugs that are common now, but at the time was new, like calcium channel blockers, beta blockers, drugs to address cardiovascular disease that are commonly used. So back then, it was discovered that these drugs were thought to be a big advance over diuretics, which were at the time state of the art, which I'm not sure they aren't still state of the art, quite frankly, which is another conversation of which we don't have to have right now. Anyway, so these new drugs were coming out, and some physicians discovered that if you combine them with two very inexpensive generic drugs, that patients were having very good outcomes. And so they said, well, let's do a clinical trial and let's see if what we're observing is really true. So they do a clinical trial and they see that this combination is very effective, right? Patients are doing really well on this. And so they published the article in New England Journal of Medicine, gets a lot of attention, and now we've got this really important new advance because we now have this new protocol for addressing cardiovascular disease that seems to really be effective. And if the story ended there, it would have been a great story, but it didn't end there. They then said, okay, what if we took these two generic drugs and put them together in one pill and got a patent on that? Then there would be an economic windfall, right? So they do that. They get a patent, and when they are ready to come to market with this new drug, FDA says, no, I'm sorry, you can't come to market. And you can't because that study that you published in the New England Journal was fine as it was, but it wasn't to all of FDA standards, so you need to do a new clinical trial. So if you've been involved in a clinical trial, then you know the length of time it would take for them to organize another clinical trial to FDA standards. By the time they finish that trial, it would be off patent, and so they would lose their financial windfall. So what do you do? Okay, they go back to the original data, and they do a little data mining, and they discover that this combination therapy is more effective in Black patients. Now, I said it that way intentionally. It's more effective in Black patients. Have you heard that terminology before? That's the way we talk about it, right? This is more effective in Black patients. That's more effective, right? What does it mean that this combination of drugs is more effective in Black patients? What does that mean? How does that happen? What is the physiological mechanism that makes this combination more effective in one group of people versus another? Well, there's some genetic thing, right, that makes it. So, no, that's not what it means. What it means is this. This is an example, so these are not the real statistics. This is just, I'm making up just for us to illustrate the issue. Let's say we had 100 Black patients, 100 white patients. They all had the same condition, whatever that condition is. And this is not a trick question. I'm going to ask you a question, so there's a test. And I will grade, because that's what I do. So you got to pay attention. 100 Black patients, 100 white patients, and this is not a trick question. They're both groups of patients, all 200 were diagnosed by the same person, right here, right? So you made the diagnosis, so you know it. And they would, the same assay, from the same lot number, from the same company, analyzed at the same labs, right? So I'm not trying to trick you. We give all 200 patients this pill. And so our results are 75% of the Black patients benefited from this drug, and 65% of the white patients benefited from the drug. Are you with me? You got me? Okay. Look, I know we're not in church, but you can give me some, yeah, right? You're there, right? All right. 75% of Black patients benefited, 65% of the white patients benefited, so there's a 10 percentage point difference, right? Now, I can assure you, you have to trust me on this, because I've done a lot of this research stuff. 10% is a point difference with 200 patients. That is going to be statistically significant, okay? So, have I now found a drug that's more effective in Black patients? Who says that this drug is more effective in Black patients? Raise your hand. Okay, I see a couple of tentative hands back there. Okay. Who says that doesn't prove it's more effective in Black patients? No, there's another group. How many of you don't want to answer because you're afraid it's a trick question? That's usually the biggest group. I don't know why. Even though I promise it's not a trick, people still don't believe me. That's okay. Well, of course, the answer is it is not more effective in Black patients. It was effective in a larger percentage of Black patients, but it's not a more effective drug for Black patients. We have not found a Black drug for Black people that will solve all Black problems. Because if you're part of the 75% of Black patients that benefited, then you benefited. If you're part of the 65% of white patients that benefited, you benefited. You didn't benefit more or less. Either it worked or it didn't work. And for those 65% of white patients, it worked, right? So this was the result that they found with Bidil. They found that a larger percentage of African American patients benefited than white patients. And with that information, they went back and got a new patent. This time, they got a patent for use in only Black patients. So the white patients that would also benefit are not supposed to get the drug, right? And then they do a new clinical trial, but this time the trial is done only in patients that have identified themselves as being black. And what do you think those results showed? That Bidil was effective. Why? Because everything we know about Bidil tells us that it is effective, whether it would have been black patients or Eskimo patients or patients from any other ethnic group. Everything we know about the drug suggests that it would have shown that there's a benefit, because Bidil apparently is an effective drug. So now we have this drug that is supposed to be prescribed only to African Americans. So now here's your problem. You're in your treatment room and a patient walks in and you think this person has cardiovascular disease and could potentially benefit from this drug. Do you prescribe it? To whom do you prescribe Bidil? Do you prescribe Bidil to this African American gentleman who has 2 grandparents from Ireland and 2 grandparents from Jamaica and was born in the Bronx? This is Colin Powell. Do you prescribe Bidil to this African American gentleman who has grandparents from Kenya and also white American grandparents and was born in Hawaii, which is part of the United States? If we could just finally let that go. By the way, his African ancestry comes from East Africa, whereas most African Americans are from West Africa. So if there is some sort of geographic genetic thing going on, it might be going on with this guy too, right? Do we prescribe Bidil to this African American gentleman? So now this guy's got grandparents from China, grandparents from Thailand. He's got grandparents from the United States, white American and Native American and black American. From whom did he inherit his Bidil receptor? And how do you know? Because if you simply ask him what his race is, he will tell you he is Caucasian, which is literally true, right, with this guy. Of course, this is Tiger Woods. And finally, do we prescribe it to this guy? Because he looks like a black guy to me. He walks in the treatment room. I might just write the script. But of course, this is Vijay Singh, who is from Fiji and is not an African American at all. But I would hope that if Vijay Singh ever needed Bidil, that it would be available to Bidil, because what we know about Bidil is that it's an effective drug. So just to close the story out, what happened with Bidil is they did get the patent, they did come to market, Nitromed licensed the drug, brought it to market, marketed heavily to just African American, mostly African American physicians. If you went to the NMA meeting, it would be impossible to walk through that exhibit hall and not get bombarded by Bidil. Of course, few people prescribe Bidil, and few hospitals put it on their formulary because everyone said, well, why would I use Bidil when I can use the 2 inexpensive generics, which cost pennies on the dollar. It's much cheaper, and everyone did that. And Nitromed ultimately got delisted from the New York Stock Exchange because they started losing money. Private equity firm has now purchased the license, and now if you go to NMA, you will find that they're back promoting Bidil again. But the question still remains, why not just prescribe the cheap generics, which is really just as effective? But the point is, 2 years after the Human Genome Project concluded that there were no genetic differences among race groups, we get the first drug approved for use in only one race group. So we spent all that money to show that race is not genetics. And then that thinking that just because skin color looks different, that therefore your genome must be different too, in spite of the fact that there's no scientific basis to believe that. That kind of thinking creeps into our brains, and we wind up having this drug only available for one race group, Bidil. So at the core of the question is, what is race? Where does it even come from? This concept that one phenotypic characteristic, skin color, is all empowering. You know, it's so powerful and overwhelming and meaningful that we ignore other forms of variation across human beings. Right? Humans vary in many ways. Skin color is only one of them, and we elevate the skin color variation to such a high level that we conclude that there must be really important differences between these groups at the genetic level, at the genomic level, and then therefore we can do things like have drugs that's only prescribed for one group. Well, this concept of race goes back to the late 1600s and early 1700s when naturalists and explorers started traveling around the world and finding other humans in other parts of the planet, and that they looked differently, and came up with this system of classification, of classifying people into these 5 groups: Caucasian or white, Mongolian or yellow, Malayan or brown, Negro or black, and American or red, on the basis of a visual inspection and the knowledge and science level of people operating in the 1700s. In 1977, the United States government, in the Office of Management and Budget, issues the first official national policy on race, on defining race, and basically goes back to the 16 and 1700 classification system, and this basically says, yes, race is these 5 groups based on what was done back in the 1700s, based on just looking at people and not utilizing the science and technology and knowledge level that was available back in 1977, and simply said officially, okay, it's going to be these 5 groups. This is where race comes from and how it's been used. Now, these next few slides I'm going to quickly show you I'm going to show you the way that race was used in every census ever taken in the United States, from the first census, which is 1790, until the last one, which was 2010. And I know that I'm breaking every rule of PowerPoint making here by squeezing all this onto one slide, so it's okay. But I'm doing it to make a point. So the point is that in 1790, this was the first census, the categories were free white males, free white females, all other free persons, and slaves. Quickly, they start to expand, right? So now, 10 years later, they include Indians that are not taxed. Then, by 1820, we're including free colored persons. 1850, mulatto gets added. 1880, now we're adding Chinese to this category. So now we've added in nationalities on top of it. By 1890, mulatto's not enough, so we've got to further segment the group. So now we've got octoroons and quadroons. 1900s. Now we're adding in, like by 1920, we're adding Hindus. Now we got religions added here as that we're measuring here with race. Black becomes Negro. Moving into the second half of the 20th century, notice how I need more lines now to fit in all the different categories, the way we're segmenting people. All right, so 1960, we get Hawaiians added in here. Koreans get added, Vietnamese, and now by 2000, I now need 4 lines just to get all the categories in. So race is a concept that is determined by political and social considerations. It's a decision that we make to define race one way versus another way, based on whatever the social and political issues are of the time. If you think about American history and when things like Filipino gets added and when Hawaiian gets added, they all track with major wars, major migration into the country. They track with Hawaii becoming part of the country, which it is part of the country, right? And this is when when this happens. So race is a social construction. It's a political construction. It's something that people simply decide that we will categorize this way on this basis at this time, and it changes based on whatever the social and political needs are of the day. So if it's not genetics, if it's not access to health care, and if it's not socioeconomic status, then what is it that's producing these racial disparities that we all see? And I would say that it's the fact that we live here in the country together, all racial groups, but we experience the country very different. largely because of physical racial segregation, that is that we don't live in the same communities and we don't have the same exposure to the same health risks, nor do we have the same access to resources that are protective of health. But that we experience, but then even when we're not segregated, there are differential experiences that we have, all of which impact health. So what do I mean by that? So this map was produced after the 2010 census. This was done at the University of Virginia. What they did was they placed a dot on the map representing every American. So there's over 300 million dots on this map. So I don't know how long it took them to do that. Each dot is color-coded to designate race. Blue dots represent white Americans, green dots represent black Americans, Asians are represented by red dots, orange dots are Hispanics, okay? So let me zoom in. First, I'll zoom in here on my city that I currently live in, which is New Orleans. So you clearly can see here in New Orleans, in Central City, you see a lot of green dots. In Uptown and in the Garden District, you see a lot of blue dots. The suburbs to the east, this is New Orleans East, you see pretty much exclusively green dots. To the west of the city, this is Lakeview and Metairie, you see almost exclusively blue dots. Now, if you got a little time to kill and you want to like take this in, just Google race dot map, and this map will come up. It's at the University of Virginia, and every city in the country is here, and you can just check it, just have hours of fun looking at how every city has its own variation on this. So now when I do this presentation, when I do show this at presentations, I always show the city that I'm in. And then after I show the city that I'm in, I say, okay, now here's my hometown, so that they know that I'm not just picking on them. But now I happen to be in my hometown, so here's my hometown. Oh, I'm sorry, that's next. But first, I just want to show you another way that this has been illustrated. This is Washington, D.C., and this is their metro system here. And so what it shows is that if you're going home from work and you're at the Metro Center stop, in that neighborhood, life expectancy is 72 years old. And depending upon which train you get on to go home, you can predict what your life expectancy is, which is interesting. So if you're on Metro Center and you get on the red line and go out into Montgomery County, which is one of the richest counties in the country, life expectancy is 81. If you're going out on the orange line into Northern Virginia, or the blue line, which is both in Northern Virginia, you actually see you're at 80. But if you get on the green line and go out to Prince George's County, which is a predominantly African-American community, it's 75 years. This is a very small geographic area. And within this small geographic area, you get this kind of variation, as much as 5 years difference in life expectancy. So here is my hometown, New York. Okay. I guess for this audience, I don't really have to do much orienting. But this is Manhattan. And this white triangle here is, right? Because nobody lives in Central Park, right? So I actually, after college, I actually worked as a social worker with homeless people this is back in the 80s, and I was working in Manhattan. So it was literally my job to call on people who lived in Central Park. And I can assure you that there are people living in Central Park because I personally knew people, literally knew them by name living there. But anyway, no one is legally and officially living there. So here I have circled Brooklyn, because Brooklyn is in fact the center of the universe, so we have circled that, right? I usually get pushback on that comment, but not here, of course, because everyone in this room knows that is true. And this big mass of green right here is where I grew up. Brownsville, which is 86,000 people living in a little more than 1 square mile. And so it did me no surprise in this audience to know how it is that we get that many people in such a small geographic area. This is how we do it. This is an aerial shot of Brownsville, and that's the building that I grew up in Brownsville. And that is the elementary school that I was supposed to go to but didn't, because just before I started, they decided to abandon the school. And when I say abandon it, I mean literally they just padlocked the building and walked away, and it sat there to rot for the next 40 years. They actually did, I'm told, just start doing a reconstruction on that building like a couple of months ago. So that is Blake Avenue and Rockaway and Blake. So if you look closely, you can see the foliage coming out of the top of the building. These are literally trees that grew out from the bottom, out of the top of the building, over 40 years. So I was there last winter to try to get pictures of it, but it didn't occur to me that the foliage wouldn't be there in the winter. Right? Maybe if I had actually been allowed to go to the school, I would have learned that, right? So I get there, but if you look real closely, you can still see some of the branches up there, you know. Anyway, so a few street scenes, examples of the food environment in Brownsville. And this is just a picture of some kids that I took, because if it was probably 40 years ago, I probably would have been one of those kids. So I took the picture of them. But when you look above their heads, you see Crown Fried Chicken. And Crown Fried Chicken is a very prominent chain here in Brooklyn. This is the food environment that you're in. So segregated communities and disparities that exist across these different community types exist because of the infrastructure. Things like the food environment that I was just showing you. So they exist because there's a different context in which people are living. And when we take these national statistics and we don't account for the fact that people are not living in the same health risk environment, and we see difference by race, then we can be fooled into thinking that it's something about the people that's producing the difference, rather than there being something about the environment that they're living in. So this is what we have to be very careful about national statistics. This is a big country, expands 12 time zones, if you include Hawaii, which is part of the United States. 12 time zones, right? And we can calculate statistics, but think about this. This is what we do in health. We calculate like death rates, and I'm even showing you some of these statistics, right? For the entire nation, without accounting for how much variation there is across the nation in the way people live their lives. What if we turned on the TV in the morning to find out the weather, and Good Morning America or whatever, and they say, today the national average temperature will be 42 degrees. Right? Now that is a statistic that can be calculated. I don't know how meaningful it is, but it actually is a knowable number that they could report. But does that tell you here in New York whether you need a jacket? Or in San Diego, whether you can wear shorts, right? That is what we rely on when we look at the health statistics, that is on a national basis, and don't account for the fact that people are living having very different experiences, and living different lives. So a couple of studies that have actually looked at this question of segregation and health have all documented that there are, in fact, differences in health as it relates to segregation. Infant mortality, adult mortality, tuberculosis rates, hospital admissions rates. So the team that I was working with, that I led when I was at Johns Hopkins, we got the idea of what if we can identify racially integrated communities? And we go into those communities and we collect data on them. Would we find the same racial disparities that we find nationally when people are living under the same conditions? Well, whether it's lack of access to care or access to other resources or exposure to health risks. So there are 168,000 census tracts in the United States. How many of them would you guess met the criteria of being racially integrated? And the criteria we used was at least 35% black and 35% white living in the same census tract. 168,000. How many of them met that criteria? What do you say? It's not a trick. It's not a trick question. There's no trick questions this morning. Well, the answer was 425. 425 census tracts in the entire country that were racially integrated, and 2 of those census tracts was in Baltimore. So, and they were right next to each other. We put them together, and we went into those tracts, and we replicated the National Health Interview Survey and NHANES, which are 2 national studies that's done, and we replicated protocols from parts of the protocols from those 2 studies to answer the question, do we find the same disparities, all right? So the study that I'm describing was done in 2 census tracts in the Baltimore area, 35% African American and 35% white, and also no significant differences in income levels or educational levels, right? So this is as close to laboratory conditions as you're gonna find anywhere with any naturally occurring population of people. And so here's just a quick profile of the community. So it was 44% white, 51% African American. Median income was very low, but as you can see, no race differences in income. So everyone in the community was poor pretty much. Poverty levels also were, for that time, high, but also not significantly different between the 2 groups. And education levels, again, very equal across the 2 groups. Right? This is about as close as you're going to get to a laboratory condition. And of course, distribution by sex is the same. And for some reason, I keep forgetting to add to the bar, to this, that red is female and blue is male. So these are 2 census tracts. We did a 40-minute interview. The interviews were done either in their homes or at one of several health fairs that we organized around the community. Blood pressure was one of our primary outcomes. And we were successful at interviewing 42% of the adults living in the census tracts. We did not sample. We went for every single person, every single adult living in the census tract, and we were successful at interviewing 42% over 12 weeks, which is an outrageously high response rate. And if you want to know how we pulled it off, I'll explain it later if you ask questions about it during the Q&A period. But it was quite a lot that went into producing that outcome. So first, how did we do as far as representing the sample? So the red bar is our study. The blue bar is from the census data. So see how well are we representing the community. I think we did a pretty decent job here. This is probably my favorite chart that I've ever produced in my entire career. That we did a pretty good job of reflecting that community. And so now what we do is we have a series of health outcomes. We have data that we have a study that we patterned after the health interview survey in NHANES. And so what we do is we go into the research literature and we pull out studies using either health interview survey or NHANES that looked at race differences in some health outcome, hypertension, diabetes, other conditions like that. And then we replicated that study in our data, okay? That's what we're doing. Yes? The national census, right. So data on that census tract from the national census, right. So, so this is just to show that I think that we did a good job of representing that community. But if you've got 42% of the adults, obviously you're going to be pretty reflective of what the census showed with that higher percentage of people. So the logic of the whole thing is that we go into the research literature, we find a study that's already been published on either, diabetes or hypertension or whatever condition it was, looking at race differences in either health interview survey or NHANES. And then we replicated that same analysis in our study to see, do we get the same results? Okay, that's the basic logic of it. And I'm not going to get, if for those of you who are not researchers, please just bear with me. I'm not going to get too researchy here, but this is for hypertension, right? And each of these models represents a different paper that somebody else published that was published in the research literature. And these are all looking at race differences in hypertension, and they all modeled it a little bit different. So they had some differences in the different variables that they used, but ultimately, each of these studies were looking at race differences in hypertension. And in each case, if you look at the NHANES column here, in each case, this odds ratio number is 2.25, tells you the difference between the groups. So 2.25 means African Americans have 225% greater odds of being hypertensive compared to white Americans. Right? That's the way you would think about that, right? So more than double the odds of being hypertensive. And each of these studies that we pulled from the research literature show the same pattern, more than 2. So it's some 2.25, down to 2.01, but whichever way they did it, it ultimately came out to be the same thing, about double the odds of being hypertensive if you're black versus being white. Now, this is what we teach in our classes, right? Probably in this very classroom, someone at some point stands at this microphone, at this podium, and says to a group of students, African Americans have double the odds of whites being hypertensive, without explaining why or any context. And therefore, the implication is that's natural. That's the way it's supposed to be. There's something biologic. They just have higher rates of their hypertension, the rates of their blood pressure is just higher, right? Well, in our study, where people are living in the same environment, under the same conditions, we actually find that our odds ratios are significantly lower. So here, when we replicated that study, we got 1.48. Here, 1.45, 1.43, 1.42. Still higher for African Americans, but not nearly as high as what we are actually teaching clinicians and health educators to go out into the world believing. Right? Is this a good condition? Is this a good situation? Right? Is there a question? Oh. It's everywhere. Right. I could probably pull 100 references in textbooks, in scientific articles, hopefully nothing that I've written, but scientific articles that show African Americans have twice the risk of hypertension as whites. And we just absorb that and say, okay, we write it down. Take a note, take your exam at the end of the semester, and you get the answer right. No context for why that would be. And the implied conclusion is because that's naturally occurring. Because there's something about being African American that causes your blood pressure to be higher. And that is true in some sense. But what is true about being African American is not something about our physiology. It's something more about the sociology, right? So we're able to explain up to 34% of this difference away by simply looking at people who are living under similar conditions. Now, we did similar studies like this for other conditions as well, not just the hypertension, but here for diabetes. In the national study, diabetes, 61% greater odds of African American being diabetic compared to white. Again, this is what we teach. We teach it every year, every day. African Americans are greater odds of being hypertensive. In the study that we do, and what we did in the community where people are living under similar conditions, we find no significant race differences in diabetes. Obesity among women. National study, 87% greater odds that a black woman would be obese compared to a white woman. When you looked at our community where people are living under similar conditions, we find no statistically significant race difference in obesity rates between black and white women. Hypertension we've talked about already, and then finally this is health of preventive health services. No significant differences there. And for the researchers and the aficionados in the room here, we've put the actual rates up so you can see what the odds ratios actually were, and the references for each of these studies is here, and I'm happy to share this with you if you'd like. So the point being that when people live under similar conditions, with similar risks, and similar levels of exposure to not only health risks, but also availability of resources that are protective of health, we see that our outcomes are much more similar than they are different, which suggests that the differences don't emanate internal to the individual, but rather they are emanating by the lifestyle, the conditions, the exposures. There was a study done, this was back in the 70s, really interesting, looking at pregnancy outcomes among at a military base in Washington State, and there they were looking at people who are enlisted in the military. So either officers in the military or the spouse of an officer, and looked at their pregnancy outcomes and found no race differences in pregnancy outcomes. And this is because they're not living in black culture or white culture. They're living green culture. They're living military culture. And in that regimented culture, things operate on the basis of protocols, and people respond to protocols. We did a study a few years ago. I had a student who worked for the Air Force and did healthcare within the Air Force. And so we had the data set for the entire U.S. Air Force and looked at disparities in that data set. And we actually found no significant race differences within the Air Force. Now, part of that is that, of course, people in the Air Force tend not to have any health problems, right? Because if you have health problems, that's one reason to be put out of the Air Force. But probably the most interesting finding, though, was when we looked at rank, that we found that the higher the rank, the less likely it is that you would be following the preventive healthcare recommendations, right? So if you're at lower level in the Air Force, like 100% of them are getting their prostate exams, getting their pap smears, whatever it is, right? Get up to the higher ranks, that's where you start finding drop-offs. People are not doing it. And if you can imagine why, right? If you're at the bottom and the officer tells you, you will go in and get your physical, you go in and get your physical, right? And if you're practicing medicine in that environment, you're practicing on protocols. So everyone is getting exactly the same treatment. If you're high up enough, there's nobody to demand that you go. Plus, if you're the general, who wants to do the DRE on the general? I mean, I'd imagine that'd be pretty uncomfortable thing to have to do. Okay. So, there are in fact 4 great disparities that cause each other and are caused by each other. And just as we're having this meeting here today talking about health disparities, there are other groups meeting elsewhere in Brooklyn talking about these other disparities. But we really need to start talking to each other, because our disparity is causing theirs and theirs is causing ours. And if we don't get a handle on the fact that this is this spider web of causation, and that is complex, and that the solutions will have to come by a comprehensive understanding of the broader sociology, then I don't know that we're going to make any progress on any of this. So we know that education is one of the best known predictors of health outcomes across a variety of health outcomes. But we also know that children that have health problems are not able to participate in school and get the greatest benefit out of it. We know that people wind up in prison, that the illiteracy rates of people in prison is extremely high, that people wind up in prison because they can't afford legal services that keep them out of prison. And we also know that the best way to ensure that a group of people will not develop wealth is for them to be in prison between the ages of 17 and 34, which is the period of life where most people develop the human capital necessary to be able to create wealth. The health and wealth relationship is well understood. We know that people wind up in prison because of undiagnosed and untreated mental health conditions, and then we also know that people wind up coming out of prison often sicker than they were when they went into prison. Right? So none of this is a surprise, I think, to anyone in this room. But when we think about the health disparities problem, rarely do we think about it this comprehensively. And if we don't make progress, because it's happening within the social determinants realm. So I just wanted to show you one other clip from this, from the Brownsville episode, which I think where a resident of Brownsville tells a story that I think illustrates some of what is producing these disparities.
This is about, I had to be like 13. I had to be like 13, bro. So whatever the case may be, my grandma's, she downstairs right now. Right there in the kitchen, she'll vouch for this whole story, she'll tell you the whole thing. She used to send me to the store. I'm talking, this is Brownsville, when you go to the liquor store, whatever age, fucking get you a Dutch, get you your roll up for your weed. Anything could go down over here if they know you, if you from the hood. You get what I'm saying? I was going to the store for Dutches and roll up and shit. forever. You know what I'm saying? So she passed me the bread, says, I need a pack of cigarettes or whatever. Cool, I'm feeling to go outside anyway. Grab my bike, right? Ready to get the cigarettes. I'm riding right here through this block. Come, let me show you. Let me show you exactly how this shit happened. Hopped on my bike, I rode through this dead end, this is my building. Went up there, right there, the sun, made the right. Went to get the cigarettes, bomb. They gave me the cigarettes at the store or whatever, right? They gave me this shit in like a brown paper bag. Like they folded it up. So it looked like some shit. You know what I'm saying? I ain't thinking that now. I know at the time it looked like some shit. You know what I'm saying? Ran in the store. Now I'm buying back, right? Yo, bro, I had cops come running out of this fucking parking lot right here. I had a detective car behind me, right? And I think the two blue mice just came after whatever, right? They threw me off the bike. Right here in front of my grandmom's in the window and everything. They threw me off the bike. All that, threw me on the floor. They ain't handcuffed me or nothing, because I was a little nigga, so they had enough control over me not to have to handcuff me. They threw me on the floor. They, what's in the bag? What's in the bag? Ain't shit in the bag. We was watching you in the back of the store, right? In the back of the store? Nah, there's some cigarettes in the back. G-Mom's in the window, but she not saying nothing, because I got that kind of grandma's. She don't want nothing to do with the Lord. You get what I'm saying? She won't even help. You get what I'm saying? It's fucked up, but it's true. She don't want nothing to do with the Lord. She in the window, I see her peeking. I'm like, nah, these are cigarettes. But all she had to do was just say, this is like, nah, that's my grandson. I said, just they popped open the bag. After throwing me on the floor and all that, they're like, oh, all right, you good. After throwing me on, not an apology, not your story checked out, nothing. It was just how we grew up. You get what I'm saying? And for some reason, to the average other person, that shit have scarred them for life. That shit have bothered them. That shit goes down around here. To this day, my grandma make those little jokes, you know what I'm saying? Oh, I can't send you to the store. I can't send you to the store. They violated me that day. Throw me off the bike, all that, bro. They probably thought I had some drugs or something.
So he makes the point, right? One of the points that he makes. And so just, I don't know if you know the neighborhood, we're actually standing on the roof in Brownsville houses when we're having this conversation. And he tells this story, and he ends it by saying, well, the average person, it would mess with them, but it doesn't mess with me. But I can tell you that when he started telling that story, he transformed into a different person. He was 23 when we were talking, and he was talking about a story that happened when he was 8, right? But it was almost like he went back to that experience. And there has to be a physiological response that's happening. I wish I had a heart rate monitor on him when he was telling that story, right? He is still dealing with the effects of that experience. And so when you're living that experience, and when you constantly have these assaults to your psyche, which manifest through us physiologically, maybe this is why African Americans have double the risk of hypertension compared to whites. Maybe this is what's going on. So I talked about prison, and I'm going to end here. I'm going to ask you this question. So how many of you are aware that there are more black men in prison than in college? Okay. Thank you. So, I would always hear that statement, and I would be like, I grew up in one of the roughest neighborhoods in the United States. I know a ton of people that went to prison, but I also know a ton of people from Brownsville that went to college. Not just me. I know other people that did as well. And even in my experience, that just didn't make sense, that there would be more black men in prison than in college. So as I am a researcher, I said, well, let's do a little research. Let's see if this is really true, because it just is not consistent with my personal experience, and maybe my experience is not normative, because I keep hearing people say it. I even heard President Obama say it once. I was like, wow. Okay, so I went to the Department of Education and the Department of Justice and pulled their statistics, national federal statistics, to see, figuring this is probably the most official statistics that we're going to find anywhere. And this is what I found. So I found in 2000, this was 2006 the first time I did this, 836,000 black men in prison. Now, please do not interpret anything that I say to suggest that I think that that number is acceptable. That is unacceptable. 800,000 black men in prison in 2006. But there were 896,000 black men in college that year, right? So there were actually 53,000 more black men in college than in prison. So then I said, okay, that was 1 year. I went back then to as early as I can go with the statistics from these two agencies, right? And said, was there ever a year where that statement was true? And what I found is that, oh, I'm sorry, I forgot. Before that, I then said, okay, the prison population, adult population, can be any age. College population is going to typically be about a 4 or 5 year span. So the best we could do in terms of lining up the two data systems was to go with the age range 20 to 29. Okay? So in 2006, 310,000 black men in prison, 480,000 black men in college. Again, more black men in college. So now I then went and said, okay, let's look at all years for which data was available. What do you find? What we find is that there actually has never been a year where this statement was true, at least up until 2010 when we stopped collecting this data. In fact, there were some years where it was close, but even here, 1998, 1999, there were still more black men in college than in prison. By 2010, you almost have 500,000 more black men in college than in prison. And let me also say that we did not include graduate school in these statistics. We did not include junior college or 2-year college in this. This is only 4-year college. So if we added community colleges and graduate schools, it would be even higher. So not only is it not true that there are more black men in prison, it is an outrageously inaccurate statement to say there are more. There's more than, is probably approaching 1 million more if you added the 2-year colleges. So here's my question for those of us in healthcare. How is it possible that something, a lie, that is such a big lie, can be so easily believed by so many of us? If I said that there are more Asian men in prison than there is in college, you would just shake your head, assume that either I was mistaken or I was a fool or whatever. You certainly wouldn't believe it. You would not repeat that statement to anyone because you know that they would think you're crazy. It would be so unbelievable. But it's not unbelievable when we say something like that about black men. So if we can believe that about black men, what then do we do when a black man walks into our treatment room? How does that affect the way that we respond to them and the quality of care they receive? And as a result, the stresses that impact their health and ultimately produce the disparities. So if you get nothing else out of this presentation, I ask you to join me in my one-man crusade to stop this terrible lie from being spread that there are more black men in prison than in college. I would also say, first of all, it's possible to be in prison and in college at the same time, right? Because many colleges teach courses in prison. Also, it's possible to be in prison for part of the year and in college for part of the year, so you wind up in both of these data systems. I believe if we could resolve that the differential will be even bigger than what we have here. So I ask that you join me in my one-man crusade to help to stop this lie from being spread about black men, and I think if we can solve that lie, we might have an impact on the racial disparities in health as well. Thank you very much.
Wow. I'd like to thank Dr. LaVeist on behalf of all of us for a fantastic keynote speech. So we have time for a few questions. Then we will go for a short break and come back for the next segment, which is starting vascular disease. So I'll take 2 questions. Okay. Yeah. Excellent. Very short questions, very short answers.
Okay. I can't promise the short answer part. That's.
Two short questions. Can we have a copy of the slides? They're great.
Sure.
Second question is, where in Baltimore did you do your survey? Just curious.
So,
Where in Baltimore was the survey done?
So what I can say is we used a CBPR, community-based participatory research methodology in doing the study, and we worked very closely with that community. And as part of that, we agreed not to name the communities. There isn't a specific community, actually. It touches on, if I name neighborhoods, it touches on several different neighborhoods that you would probably recognize, but no one neighborhood is fully in the study area. So it's pieces of a number of neighborhoods. And so all we say is southwestern Baltimore. So you can, if you know Baltimore, you can probably think about what that would be.
Okay. Question, please. Short question.
Yes. Short question. Would you agree that the problem of racial disparity is based on explicit bias, not so much about access to care?
Bias.
Yeah. So is explicit bias at the core of what Black people are experiencing in terms of disparity?
So to repeat the question. So is this due to explicit bias? That's the question.
I would say both explicit and implicit bias are issues here. Like when I was talking about this issue around the prison and the fact that we would believe that there were more Black men in prison, I think that all fits into the implicit bias issue, that there's this underlying belief system that allows us to have certain beliefs, and as a result, we do act on that. So I do think implicit bias is important too. There are explicit biases too, and then when you look at things like environmental justice issues and targeting certain communities for exposure to environmental hazards, I think some of that is explicit. So I would say there's a combination of both implicit and explicit bias when you bring all of these things together to explain the racial disparities.
Okay.
Thank you very much for this talk, Dr. Williams. So would you say that the racial disparities in chronic diseases are moderated by segregation or dissimilarity? If you use the dissimilarity index, that would moderate the disparities that you see?
Yeah. Well, let me repeat the question. So that the question was, if we were, I'm going to try to, I'm trying to think about how to say it.
If you're trying to explain, because you showed that much of the variability was due or explained by place, so the
right.
segregation or dissimilarity.
Mm-hmm.
So is that, can you say that itself was a, I guess, a moderator?
It's a.
Can I rephrase the question?
Yeah.
I think the question has to do with what is the contribution of segregation?
Yeah.
Let's say, in your opinion, as a percentage to the problem.
Yeah, but you use explicit. You use epi language, and that's why I was trying to.
We talk about this epidemiologically, but
right.
to understand, like what changes at what levels do you see these?
Right. Right, so that's why I'm kind of struggling to answer it from epi framework. So from that framework, what I would say is that the segregation, I wouldn't think of it as a mediator. I would think of the other predictors as the mediator. I'm sorry for the non-researchers to have to get into talk like this. I think it's not a mediator as much as that it is. I think it's a precursor to the determinants of the health. So to use hypertension, it's a precursor to the determinants of hypertension. It determines who gets exposure to what level of risk, right? So the actual determinants are the mediating segregation and the health outcome.
That's a big question. So maybe you can.
Yeah, it's a.
Outside. Any question?
It's a complex question.
Can you introduce our commissioner? Yes. No, we will introduce you first.
Okay, so I'm pleased that we have with us today Dr. Torian Easterling, who is the Assistant Commissioner at the New York City Department of Health and Mental Hygiene, and he also right now is running the Health Equity Unit, which is unfortunately not in Brooklyn, where he usually was located, but is in Queens. So now, Commissioner, you can ask your question.
Okay. Dr. Peace, thank you so much for showing this slide at the end. It sort of level setting the narrative about Black men in college versus prison. I wanted to just link back to
Oh, oh, yeah.
Just the other part was just thinking about the interruption, because there are a lot of people who are on parole and have, electrical monitors on that interruption into college.
Right.
So just sort of thinking about that. And the other thing that you alluded to was the outcome is, and the output is having a college degree. And so that interruption that happens during that entire journey from being in jail to prison and not going back to college, do they end up with their college degree? So just sort of think that.
Right, so so I actually usually explain this, and I didn't, because I talked about the college part, that we only use four-year colleges, right? Because I wanted to be really conservative, so we didn't put junior colleges in. Now, that number for the prison is prisons and jails. So it's both federal prison, state prisons, and local jails. So it's all prisons that are included in this. So that answers that. And you were talking about the interruption issue. I really didn't think of it that way. I just thought I was just responding to the statement that people make. There are more black men in prison than college. And I just said, okay, does the data bear that single statement out? And it does not. Now, clearly there are too many black men in prison. There are black men on parole, and various, people are in various stages of the prison system. And that's a complexity that really wasn't something that I was looking at, because that's not the statement people make. The statement people make is there are more black men in prison than in college. And I just wanted to dispel that single statement.
All right, please join me in thanking Dr. LaVeist. 5 minutes.